Hi, my name is Koen Baas, and in this video I'll present our latest work that has recently been published in JMRI titled Comparative Analysis of Blood T2 Values Measured by T2 TRIR and Trust. So our work is about measuring the venous blood oxygenation, or YV, in the superior sagittal sinus. And this can be a useful measurement because together with an estimate for arterial oxygenation, the oxygen extraction fraction by the brain can be estimated. And if you also include cerebral blood flow measurements, the cerebral metabolic rate of oxygen, or CMRO2, can be derived. So together, these measurements provide some insight in the oxygen metabolism of the brain. So one way to estimate YV is by measuring the T2 of blood, and a technique that allows us to do so is called T2 relaxation-under-spin-tagging, or TRUST, which was introduced by Liu et al. In 2008 and since then studied extensively. It's a sequence similar to arterial spin labeling. You have a labeling plane which is now above your imaging slice, and you acquire label and control images. The sequence also includes a T2 preparation module, which results in effective echo times of 0, 40, 80 and 160 milliseconds. After this T2 preparation, you do a slice selective readout. If we look at a TRUST dataset, you notice that the label and control subtraction isolates the venous blood signal. And if we spatially average that signal, we can do a mono-exponential fit to obtain blood T2. To get from blood T2 to venous oxygenation, an empirically derived calibration curve is used. The model shown here is for healthy controls, and it shows the relation between T2, hematocrit and venous oxygenation. So a small downside of this approach is that you need to determine the hematocrit, which is an invasive procedure, which you might not want to do in your study. And a way to possibly overcome this is by measuring the T1 of blood, which is known to be linearly related to hematocrit. And this is what the T2 TRIR sequence aims to do. T2 TRIR stands for T2 prepared blood relaxation imaging with inversion recovery and was introduced by Peterson et al. In 2012, but since then has not been extensively optimized yet. So how does this sequence work? T2 TRIR is actually a modification of the TRUST sequence. We now have a global inversion, and the inversion pulse and the T2 prep module are switched. We also do multiple readouts instead of one, so that you can sample an inversion recovery curve. So the goals of this project were as follows: to optimize the T2 TRIR sequence and data processing. Therefore we used different inversion pulses and came up with a strategy to automatically select an ROI. To compare T2, YV and OEF values from both techniques, and to compare their sensitivity to hemodynamic changes using an acetazolamide challenge. The first part of the study was a test-retest study in 12 healthy controls. 6 of them were women and their mean age was 27 years. All subjects underwent 2 sessions. In the first session, the TRUST and TRIR scans with tilt and hyperbolic second inversion pulses were repeated. Then the subject was taken out of the scanner and repositioned, and during the second session all scans were repeated once more. We also acquired phase contrast scans to measure blood velocity, and unfortunately, due to our software patch, the TRIR scans with the hyperbolic second pulse had to be performed at the end of each session and could therefore not be randomized as was done for the other scans. The second part of the study was done in 7 patients with sickle cell disease. 5 of them were women and their mean age was 32 years old. Both scans were performed at baseline and 10 minutes after administration of acetazolamide. Acetazolamide is a vasodilator which causes an increase in blood flow and ultimately a reduced oxygen extraction fraction. TRUST processing was done according to literature, but in short, label and control images were subtracted. Then the 4 voxels with the largest delta M were used to spatially average the signal, and through these signal averages a mono-exponential fit was done to obtain blood T2. For T2 TRIR, processing is less straightforward because there is no subtraction of label and control images that isolates blood signal. So therefore we had to develop a robust method that prevents user bias during ROI selection. Our method starts by roughly selecting the sagittal sinus, so the algorithm knows where to look. Then the 10 highest voxels are selected from within this ROI. Then the signal fit is done for each voxel separately, and the voxels with a fitting R squared lower than 0.9 T2 lower than 40 milliseconds or an inversion efficiency lower than 0.6 are excluded because they are not likely to represent blood signal. With the remaining voxels, each combination is tested and the combination that results in the highest fitting R-square are used. These voxels are then used to spatially average the signal and used for simultaneously fitting of blood T2 and T1 using this model. You can see the data and fit in this figure. In the TI direction you see the T1 relaxation, and in the effective echo time direction you see the T2 decay. And we published all of our code on GitHub so that other users can use the same ROI selection approach. In the last step, T2 was converted to YV using the Bush model for healthy controls and the Lee-Bush model for sickle cell patients. And that brings me to the results. If we look at the blood T2 estimates, we observed good within and between session repeatability for both techniques. Additionally, we observed good T1 repeatability for the TRIR sequence as well. However, there was a bias between the T2 values from TRUST and TRIR. TRIR consistently resulted in higher T2 values compared to TRUST. In controls, this was almost 10 milliseconds on average. In patients, this was even higher, 17 milliseconds on average. We do have an idea on why this bias occurs. If you look at the TRUST sequence, you can see that the blood is very close to the imaging plane at the moment of T2 preparation, as shown here in green. For TRIR, there is more time between the T2 preparation and the readout, and thus the blood is further upstream the vasculature during the T2 prep, as shown here in blue. This gets worse for each TI, and since YV is higher upstream the vasculature, T2 will be higher as well. And since every readout contributes to the final obtained blood T2, we think this effect causes the bias between TRUST and TRIR. Therefore, we also fitted the T2 for each TI separately, and indeed T2 increases for later TIs. We also included some simulations on this effect in our work, but I won't show these in this presentation. Lastly, both techniques were able to detect significant changes in blood T2, venous oxygenation, and oxygen extraction fraction after administration of acetazolamide in the patients with sickle cell disease. So in this work we optimized the T2 TRIR sequence and its data processing. Both TRUST and TRIR showed good within and between session repeatability, and additionally T2 TRIR offers repeatable T1 estimates. Both techniques are sensitive to hemodynamic changes, as shown by the acetazolamide challenge, but there was a bias in blood T2 between TRUST and TRIR. So to conclude, TRUST and T2 TRIR are equally reproducible, and TRIR allows reproducible T1 blood measurements, possibly overcoming the need for invasive blood measurements to estimate hematocrit. T2 TRIR derived T2 values are significantly higher compared to TRUST, which might be due to the fact that T2 TRIR reflects blood T2 values from different parts of the vasculature. And with that, I would like to thank you for watching this video, and of course thank all co-authors on this work. And I'd also like to acknowledge the funding we received from NIH.